No, you just buy the big ones, and then they get them in the packet. So.
He's proud.
He is.
This woman from Baton Rouge who moved here, saw the band at the park. They didn't like it at all.
There was a lot of everything. He's very sharp. She did not like the language.
Yeah.
That's exactly what she said. He lectured me all the time.
So anyway, she felt great when she was on complex immunotherapy, including mold and cockroach and stuff. She needed down there. He said none of that's necessary. Cut it to usual. When she goes back to visit her family, she's miserable. So Dan had that case. And, he tested her all the stuff that the guys in New Orleans had tested her too.
Positive.
Yeah, positive.
And then, speaking of that, what is it? Yeah. I remember our student speaker.
And then we had to figure out how to write like 30 ingredients and 30 mixes. And
We couldn't have done that.
put the right things together. Great one.
Oh God, I'm sure.
Yeah. So Brendan talks about that. Cockroach, that was a major bug. Terrible. And the cockroaches. That was notoriously bad asthma. Bad cockroach allergy. Usually one of the least attended treasures of the people. Oh, thank you all. I told you about this young lady, but she had a pretty complicated case of, she's 6. History of like multiple episodes of anaphylaxis. IgE of like 22,000 back in December.
Yeah.
Got developed leukemia and has a biochemical AML here to get a transplant. And we were responsible for last Harvard clip regarding like all these episodes of anaphylaxis and we were worried about it. We gave her a dose of Xolair. Her IgE had got that and just when she went for a graft, did everything great. And then the day after,
what's up?
she was drinking all drank infection. This is, mind you, after total body ablative chemotherapy with transplant anaphylaxis. And we're going to give her another dose of Xolair, but what I want to do is see if we can get a free IgE level on her. What's going on?
Yeah.
So obviously 800 was before she got so she can't get her.
After.
Well, let's go ahead.
I asked him, and he said, well, they're not doing it.
Is there anyone else who got free IgE from?
I think the people at IBM again.
Yeah. Sorry about that.
I think she already asked you about free IgE levels. You got this unique case. Is the company not doing it, or can we find a resource where it could be done?
Yeah, I think Noel Griffin would be the person to get in touch with. I think it's actually only done in Switzerland right now. And, but I don't know whether, I certainly don't have access to it. She may. So let me get Noel in touch with you. She's our MSL. Would that work?
Yeah, you can have her, she give me your email. case.
Is
Is
this,
it's a unique circumstance.
yeah, is this the same one that we were trying to get information on before?
Can't have nice things.
There will be a little girl who's identified as having high IgE has come down.
I don't see your son up.
Wrong business.
Well,
One dose of the second dose of the I'm very curious what
You can get some blood and hold it.
For sure, you can get it.
Urgent.
No, absolutely. I just want to have to see what the plan was.
so I just want to understand what you're telling me, in the sense that you've given her Zola and she's analyzed twice on Zola.
Not two Zola.
Okay.
Not Tuesday.
Okay, I misunderstood.
No, no, no. That was a preventer. She's anaphylaxis. Had like maybe 3 or 4 years since she was 1 and very bad.
Okay.
Yeah.
So, but no,
Morning. Yeah, let me give me your email address, or I think I have it, but let me double check. And I'll get Noel in touch with you. And if anybody has access to that, choose the person. You know, I'll do that. Yeah.
Not an over, this is eager group this morning.
Usually a case this week. Frankly, saw formally. I think they're going to challenge her. The team was thrilled about it, but we left them recommendations if they decide to do it.
You've been in touch with Mr. Goliath?
It's a relief.
Is he coming in?
You will come whenever you are.
Yeah.
Well, we have to make it now, so we know he's coming.
I got a
You'll be
call
there.
from her yesterday.
Next Wednesday.
Okay.
She was just.
All right, well, we've got to get to the east side, and Dan's got to get to an aspirin or something. I don't have a big audience.
No, I agree 100%.
You said,
They were very happy. Yeah, appreciate it.
Still need samples sometimes.
Yeah, that's true. You don't have a new version. Yeah, no, actually.
Oh, what?
You don't have a new version from yesterday. 2 weeks. It's been great.
Great to have them.
Yep.
I'm happy. Yep, that's the whole idea.
Yeah, by definition, patients are what?
We're still that way.
Yeah. So far, so good.
all right, well, we got a
One year, somebody give me a call.
core,
Yeah.
hardcore people here today. It's too wet for everybody else. We'll go ahead and we've got journals today. The word of the day is Tulane. And the usual announcements here. Everybody today, I think, speaks up. That's not going to be a problem for those on the outside listening in their PJs. The only announcement beyond that I have is I've sent out an email mentioning that we want to have our private dinner this year in Houston, just like we had last year, not sponsored by pharma. And I'm trying to work on that early this year. So anybody who knows they're going to the meeting and hasn't responded to that, I'd appreciate it if you did, so I could get a reasonable head count early on and select the restaurant and make the arrangements ahead of time. Last year, I got a place that closed entirely, and we had the entire facility for ourselves, and I'd like to do that again if the group is big enough. So anyway, don't unwrap, or if you're going to unwrap anything, do it now. And Drew's going to get started. Actually, there was an overlap, so he's got a talk that actually we did not send out yesterday, but he can send it out for anybody who wants it, and then we'll go from there.
I'm going to call out one of the fellows. Dan is a real jerk and chose the same talk as I did. He actually did a better job than I. So, he's going to talk to you about Eosinophilic Esophagitis and IgG4. So I scrambled yesterday to figure out what to talk about, so I decided to pull out an old classic here. This is a talk I gave over 4 years ago now. the diagnostic approach to hyper-IgE syndrome. So I'm going to fly through this. Both the fellows have done a great job with their talks. Hopefully we'll allow for enough time. This is pretty typical. You know, our fellows, Sydney got a talk or a call about this recently about a young kid with severe eczema. Very typical. You know, Staph aureus infection, may have had an abscess in the past, may have had a pneumonia. You know, the physician checks an IgE level and it's very high. You know, not atypical as we all know for atopic dermatitis, but their question is, what are the odds that this patient could have hyper-IgE? So the good, as you know, we do have great testing for this. A STAT3 gene, DOC8, there's a lot of implications. These patients need to be diagnosed, implications for treatment and genetic counseling. So the bad is, and David may be able to talk more, but last I checked, it was $1,500 to screen, to do gene screening for the STAT3. Not sure about the DOC8, but it's not something we can throw every kiddo that we see with eczema, elevated IgE, and eosinophilia. So what separates these patients was my question, and I review this at least once or twice a year. We get referrals to see whether people are at risk or we suspect hyper-IgE, and as you can see, 2 familiar names on this paper, and I've gotten a lot of use out of this over the years. So the STAT3 mutation, this is old news. It was newer when I presented it 4 years ago, but this patient presentation with eczema, elevated serum IgE, as you know, it can be severely elevated in our atopic dermatitis patients. And then these questionable pneumonias they come in with. So Job syndrome was first reported in 1966 by 2 females, unrelated, with these cold abscesses. When they say cold, meaning there's not a lot of inflammation around the side of the abscess, and I have a picture in a coming slide. The Hyper-IgE syndrome was introduced in 1972. Additional features you see, the hyperextensible joints. I always have a problem with this, seeing them in clinic. You know, what's hyperextensible, what isn't. Abnormal shedding of primary teeth, thought to be pathognomonic. They say after age 7, if dentists have to go in and remove their primary teeth so the secondary teeth can come in, that's one of the red flags for this. Scoliosis, and then bone fractures with minimal trauma. Here's a patient with hyper-IgE. You can see the wide nasal bridge. You can see their eczematous features there. There's one of those cold abscesses. If you had an abscess this big, you and I would have much more surrounding erythema, but that's why they call them cold. There's a pneumatocoel, and that's another red flag for this disease. Severe scoliosis, and then this mucocutaneous candidiasis that goes along with it. So we all know most of this. The autosomal dominant form is a STAT3 mutation, and then there's this autosomal recessive form, which is rare, recurrent viral infections, and involves a CNS without the connective tissue and bone abnormalities you usually see with the other forms. So it was an NIH study. They took 78 patients. 50 of them were male. The median age was 20 years. And they sent them to these tertiary referral centers. Most of them had an NIH score, and I'll go over that NIH scoring system in a subsequent slide, of greater than 20. They did all mutational analysis in all of these patients for STAT3. If that was negative and there was high suspicion, they did the DOC8 sequencing. This is interesting, and I know Troy and David do this assay. They did intracellular staining for IL-17 and the CD4, so Th17 cells, which I've run a few times, and I find useful in evaluating patients for this disease in a certain population. So, as we all know, we've had talks on this, that family of transcription factors, a key role in cell development, differential, and death. Basically, they don't understand why a lot of the clinical features present, but there's a wide range of things that STAT3 molecules, signaling molecules do. So one of the main things, and what's thought to be responsible for the infectious sequelae, is the inability to make these Th17 effector cells. It's thought to play a prominent role in controlling common infectious agents, fungi, bacteria, the organisms we see in these patients. So, I always got these calls, and it's the middle of the night or late afternoon, and they want to know what the odds are. So as you can see, it's really easy to go through this scoring system really quickly. But the some of these things you can't go through. The pneumonias, the skin abscesses, the retained primary teeth, it's fairly quick. But you want some high-yield questions to ask over the phone to kind of categorize who's at high risk and who isn't. You know, there's a lot of subjectivity, which is why I bring up these right here. You know, whether characteristic facies are mildly present. I don't know what mildly present is. Or hyperextensibility. Again, I don't know how to classify who's hyperextensible and who isn't. So there is a lot of subjectivity. So it's not the easiest thing to run, and I do it 2 or 3 times a year, and it takes me a while to go through all of these questions with them. So 78 patients were evaluated for these STAT3 mutations, so a relatively high number, and actually 48 were found to have the heterogeneous mutations. So obviously there was high suspicion in a lot of these patients going to these tertiary medical centers. Probably not as high when I've looked for it, but there were 7 novel mutations and 17 previously reported mutations in the STAT3. So the clinical findings most common are eczema, elevated IgE levels, and blood eosinophilia, which aren't much different than the atopic dermatitis patients that we see every day. So sensitivity is very high for those things, but it's a very poor specificity. So they look for other things. What's specific for the patients with Hyper-IgE? And these 7 things came up. Internal abscesses, which obviously aren't common in the general population. Nematocele, another thing that's not very common. Severe infections, they define as a hospitalization, severe pneumonia, things of that sort. Mucocutaneous candidiasis, I always ask about. Fractures without or with minimal trauma or without adequate trauma. Scoliosis, and a family history of Hyper-IgE. So, of the patients with the NIH scoring system above 40, 46 of the 49, so that's a pretty impressive number. And anyone that has a score greater than 40, I would jump, don't know why I did that, I would jump straight to the gene sequencing. One of the 3 patients that didn't have the STAT3 mutation had a DOC8 mutation. So if you're at a score above 40 on the NIH scoring system, it's very predictive.
Can you remind me what DOC8 does?
David? It's a transcription factor of some sort.
Transcription factor?
I think it's a protein it has to do something with cytoskeleton.
What's actin cytoskeleton?
That makes sense, because some of these patients, early in the phenomenology, before any of
I'm embarrassed to say that.
they have chemotactic defects. I think is one of the reasons that their abscesses are cold, is they don't have normal neutrophil or mononuclear cell chemotaxis. I know that because Cliff Furukawa and I published a paper on it.
Really?
Yeah, way back.